Thanks very much for the invitation to speak. That's the first time I've heard a general surgeon compliment a gynecologist. That's quite an event. We're going to go on a slightly different track. I'm going to talk about ovarian cancer surgery, and particularly when we should be performing this. This is quite an old slide, but it's deliberately an old slide. You can see that ovarian cancer is the fourth most common cancer diagnosed in women, and the mortality still remains up there as the fourth most common incidence of death in cancers in ladies. You can see that endometrium in 2000 was way down the list, but endometrial cancer has jumped above ovarian cancer, and endometrial cancer is now more common than ovarian cancer in Western societies. And that's particularly important in terms of radiotherapy services, which obviously we're now going to be offering in Cork. But you can see the talk today is about ovarian cancer. It's a common cancer, and lots of people die of ovarian cancer. Your lifetime risk of ovarian cancer is 1 in 70. Different types of histological types, most are epithelial tumors, and that's what we're going to be talking about today. Some of them have a hereditary predisposition, and BRCA1 and BRCA2 are well known, and also HNPCC. This is just a picture of a laparotomy. You can see two large ovarian masses, and those are both cancers. Stage 1 ovarian cancer confined to the ovary up to stage 3 and 4, where you got advanced ovarian cancer. The sad fact is that most ovarian cancer present at a late stage, so stage 3 or stage 4. Ovarian cancer is not really a locally invasive type tumor. It spreads via surfaces. The abdomen is a cavity lined by coelomic epithelium or peritoneum, and the ovarian cancer spread via that coelomic epithelium along surfaces. You can see on the surface of the ovarian cancer there, those tumor deposits. If you look at the peritoneal cavity, those tumor deposits in advanced ovarian cancer will be all over the surfaces of the peritoneum. And as stated, the majority will present at this late stage. And you look at the 5-year survival of each of the gynecological malignancies, you can see that the 5-year survival of stage 3 and stage 4 is around 30%, i.e. advanced ovarian cancer. And it's advanced ovarian cancer we're going to talk about now, because that's the most common presenting stage. Uterine or endometrial cancer tends to present at stage 1, and you can see we have a very high survival rate. So it's the timing of ovarian cancer surgery is what we're going to be talking about in advanced ovarian cancer. So the traditional approach to surgery was to start off, to treatment, I beg your pardon, was to start off with primary surgery and then offer chemotherapy. There was then a small vogue for going to primary surgery, then chemotherapy, followed by further surgery, and followed by chemotherapy. And nobody is really doing that anymore. What is coming more into fashion, which is what we're going to be talking about now, is giving neoadjuvant chemotherapy and then performing interval surgery and then following up that with chemotherapy afterwards. And what we're going to be doing is talking about whether we should be doing this traditional approach or the neoadjuvant chemotherapy approach. So what are the advantages of primary surgery? Well, first of all, you get a histological diagnosis by doing your surgery, therefore proving this is an ovarian cancer. Sometimes the ovarian mass can be huge, up to 30 or 40 centimeter ovarian mass within the abdominal cavity. Removing that can release pressure effects. Draining ascites surgically can also help. It may offer nutritional improvement if the patient can't eat or drink, very much because of the mass effect. Then by doing the surgery, they may be able to eat or drink more. And the whole idea of debulking surgery is to remove volume of tumor, therefore leaving small volume of tumor left, so chemotherapy can penetrate those small volumes of tumor left and enable the chemotherapy to work more beneficially. And although we talk about ovarian cancer, if you look at an ovarian cancer abdomen and take biopsies from individual areas, each of those individual areas will have a slightly different gene mutation, so each bit of cancer within the peritoneal cavity will be slightly different from the other one. So the more volume of cancer you remove, the less chemoresistance subtypes will be remaining, and therefore more chance the chemotherapy will work. And some patients prefer surgery over chemotherapy. They will need the chemotherapy anyway in advanced ovarian cancer, but people see surgery as the gold standard of treatment. And if you look at survival after debulking surgery, if we look at volume of residual tumor remaining after the surgery, so as I said, the cancer spreads throughout the peritoneal cavity. You can't remove all the tumor physically. There will always be something left, but it's the volume of tumor that remains after surgery that gives you a guide to the survival. So if you have no visible nodules of tumor left, your survival is much greater than if you have suboptimal surgical treatment. And if you look at that in terms of number of nodules, you get the same type of pattern. Now, this is very controversial data, because is this related to the ability of the surgeon to resect as much visible tumor as possible, or is it related to the tumor itself? So if the surgeon can't resect the tumor to its maximum extent, is that related to that tumor being more aggressive in the first place? And that's very controversial. In other words, is it really the degree of debulking that's important, or is it the nature of the tumor itself, which can't be debulked, which means the survival is less? But there are disadvantages in doing primary surgery. First of all, it's a morbid procedure. Somebody with a lot of ascites is pretty unstable as it is, and let alone then having a general anesthetic and a large surgery. There's potentially a greater chance of damaging bowel and having a stoma. And there are some patients that are not physically fit for surgery due to their imbalance, due to the ascites and the pleural effusion, etc. And also you have to recover from your surgery, and remember, you need chemotherapy. If you've got advanced ovarian cancer, you need chemotherapy. And if you've had surgery first, you won't be fit for chemotherapy, potentially for some weeks. And it may be that you think it's an ovarian cancer and you operate, and in fact it's a bowel cancer that was mimicking an ovarian cancer, or it could be some other type of tumor. And so you may be doing inappropriate surgeries. And again, as saying, you're delaying the chemotherapy. And if a patient is chemo-resistant with an advanced ovarian cancer, performing surgery is a complete waste of time. So if you're doing surgery first and the patient then turns out to be chemo-resistant, you've wasted surgery on that patient and the morbidity associated with it. So therefore, it was then thought, well, maybe we should do interval debulking surgery by starting off with chemotherapy, which would mean the chemotherapy could start straight away as soon as the diagnosis is made. There are potentially less contraindications to the chemotherapy, maybe less risk of performing suboptimal surgery, and you can plan your surgery well in advance because you know when the chemotherapy is going to be delivered, and you can plan your surgery at the appropriate time. And then maybe the reduced risk of bowel resections and possibly improved debulking ability. And you're self-selecting those patients who are chemosensitive. So if they've responded to chemotherapy, operate on them. If they haven't responded to chemotherapy, don't operate on them. It's not going to have any benefit at all. But maybe surgery after chemotherapy is dangerous because there could be hematological complications, or then maybe the patient still can't eat and drink because they've had a lot of chemotherapy. So it was on those questions that various trials were done looking at the role of interval debulking surgery. And in 1994, the initial trial suggested there was no difference or no advantage to interval debulking surgery. A further trial by a Dutch group in 1995 also suggested that maybe, in fact, interval surgery improved the survival of patients rather than giving them primary surgery. So then two large studies were embarked upon. One was called the CHORUS study and the EORTC studies that both enrolled and recruited at the same time. And what I do love is these people that invent these abbreviations, CHORUS, chemotherapy or upfront surgery. I think that's brilliant. So the CHORUS study was published in 2015. And I don't expect you to read the abstract, but what I want you to see from the final interpretation is, in women with stage 3 or stage 4 ovarian cancer, in other words, advanced ovarian cancer, survival with primary chemotherapy is non-inferior to primary surgery. In other words, it's acceptable to offer interval surgery. So that's really sitting on the fence because there's no advantage, no disadvantage in terms of overall survival. So not really a punchy abstract interpretation of that data. So let's pull the data out a little bit. So here's our CHORUS study, and now also including the EORTC study. PDS is your primary surgery group. So these were randomized trials. This group had primary surgery. This group had the primary chemotherapy. So you can see the complications in the patients that had primary surgery were 24% versus 14%. So high-risk complications. discharged within 14 days. So with the primary chemotherapy, who then had interval surgery, 90% of patients were discharged within 14 days. But in the primary surgery group, only 74% were discharged within 14 days. So in other words, these patients were undergoing a lot of morbidity because of the surgery when you had primary surgery. And if you look at the other trial, the sepsis rate was lower if you delayed your surgery, and the fistula rate was lower, and the bleeding rate was lower. So that previous summary that it was okay to offer interval surgery was really a bit of a cop-out, because a lot of those surgeons that enrolled in that study didn't like the conclusions of that study, therefore didn't want to say we should be doing interval surgery. So if you look at that data, we're saying that surgery after chemotherapy in advanced ovarian cancer is safer. Therefore, all gynecological surgeons will then offer interval surgery. Do they do that? No, they don't. They've ignored the data. And why do they do that? That's because one of the critics of these two big studies that were performed, saying that the surgery that was undertaken in these advanced ovarian cancer groups wasn't proper surgery. What do I mean by proper surgery? I mean ultra-radical surgery. That's where these surgeons will strip diaphragms. There will be 2 to 3 bowel resections with anastomosis. They'll be removing spleens. They'll be stripping peritoneum from every single surface possible. And those surgeons will say that the patients recruited into those initial studies didn't have ultra-radical surgery, therefore we're just going to ignore that data. So, a year later, another group had been recruited, had been recruiting their own patients, so this is now a single center randomized trial, and these group of Italian surgeons were the ultra-radical surgeons that were stripping the diaphragms, bowel resections, splenectomies, removing as much as they possibly could. So patients randomized between two groups and offered primary surgery, ultra-radical surgery, or primary chemotherapy with interval ultra-radical surgery. And they published their data. Again, a big abstract. I'm not going to show you much more of that. This trial hasn't got the long-term outcomes of the survival of these patients. But let's just look at the complications in the two groups. Randomized data, primary surgery, interval surgery, i.e. surgery after chemotherapy. So the mean operating time, 450 minutes versus 275 minutes. I would wish I could have 450 minutes to operate on a patient. I'm sure Harry would not be happy if I was filling a whole surgical theatre for the whole day to operate on one patient. This is just not the real world. And you're talking about a 2-hour difference. So even the patients that underwent interval surgery, they were still having very long operations, but up to 200 or 300 minutes less surgical time. The blood loss was less in the interval surgery group. The patients transfused were less. The hospital day was significantly less. One patient went home after 3 days after primary surgery. They went home in a coffin. The reason that is 3 days is because of that one patient. 80 days in hospital after primary surgery, ultra-radical surgery, versus the interval surgery group, most of those patients were going home in a much shorter period of time. And again, remember, if you have advanced ovarian cancer, you need chemotherapy. But if you have ultra-radical surgery up front, you delay your chemotherapy significantly. And if you look at the complications and the deaths, etc., again, 2 deaths in the primary surgery group directly related to the surgery, no deaths in the interval surgery group. So we still await the long-term outcomes of this trial. And I hope when they publish those long-term outcomes that they include those patients, 2 patients that died because of the ultra-radical surgery that took place before the chemotherapy. So what do we do in Cork? Well, as Brian alluded to, we have a multidisciplinary team meeting where we have access to radiology, we have access to chemotherapy consultants, to surgeons, to myself, and to pathology and to the oncology nurses. So we can discuss cases at entrance to the hospital, or to the system, should I say. So every patient with a presumed advanced ovarian cancer will get discussed before they undergo their treatment. And there are some patients with advanced ovarian cancer that should undergo surgery first. Those patients that have huge, large ovarian masses that physically removing the mass will give them symptomatic relief. We don't have any delay in our chemotherapy starts or our surgery because everything is able to be well planned and we have good access to our facilities. And we submit a lot of patients to trials involving chemotherapy, and we have good coordinated nurse input from there. But in God we trust, and everybody else must supply data. So what we're going to be doing now with medical oncology and myself and the multidisciplinary team have been working together. We're now going to start looking at our survival outcomes to see if our survival outcomes are similar or better than the expected outcomes that we have. But what we don't, unfortunately, have is NCCP KPIs, key performance indicators, have not yet been introduced in gynecology. I know that if we looked at that data in Cork at the Bon Secours, that our KPIs would be would be very good and well within our expected KPIs if we compared them with breast, etc. And hopefully those KPIs will be incorporated into all gynecological cancers, and we would certainly collect our data in the bonds to make sure that we're well within the normal limits. But certainly survival data we will be looking at very shortly to make sure after a period of working in the bonds for 8 years, we can see that our survival data is akin to the rest of the population. But my summary of the talk is interval surgery is better than primary surgery in advanced ovarian cancer. Thank you very much.
Thank you, Matt. Any questions for Matt?
The oncologist would have to ask a question. So thank you, Matt. That was a very nice talk. I was wondering whether you could foresee a time when surgery is not required for advanced ovarian cancer and the oncologist can do everything.
Yep. I think that would be particularly in the primary peritoneal tumours where the volume of tumour is actually quite small. And as you know, we get some patients with a primary peritoneal tumour, which is similar to an ovarian cancer, but the tumour has probably arisen from the coelomic epithelium. After 3 cycles of chemotherapy, there is no volume of tumour to physically see to remove. And I do question already whether we should be operating on those patients. So I think that day will come, but I still think we're going to get those patients that have a decent volume of tumour that will still require surgery to remove that volume of tumour. But I would hope that one day I would not be operating on gynecological ovarian cancer, no.
Dr. Hewitt, you mentioned that endometrial cancers have become more common than ovarian cancers of late. Is there a reason for that?
It's obesity. So endometrial cancer, the vast majority of endometrial cancer is endometrioid in type. In fat cells, you have an enzyme called aromatase, which converts steroid hormones into estrogen. So obese people have more estrogen circulating, and that estrogen stimulates the endometrium, and then it becomes hyperplastic and then becomes an endometrial cancer. So that's the reason why. So America beat us to it in terms of endometrial cancer jumping above ovarian cancer because their obesity rates are much higher earlier, whereas now Ireland and the UK have that data has eventually caught up. So it's down to obesity, which adds a further difficulty because then we have to operate on those patients and they're morbidly obese. So we're operating on patients with BMIs of 55 and things like that, which we're doing laparoscopically, but it's hard work and will continue to be a huge problem in the future until we get our obesity rates lower.
Okay, can we let Matt go? Thank you, Matt.